Hello, I'm Roger McIntyre. On behalf of CME Outfitters, I'd like to thank you for participating in BriefCase, 4 of the 4-part CMO BriefCase series entitled Treatment Hurdles in Schizophrenia and Bipolar Disorder, applying real-world cases to overcome challenges in real-world management. This edition of the CMEO BriefCase is titled, Can We Talk? Strategies to communicate LAIs as an effective treatment option for bipolar 1 disorder. The goal of this activity is to incorporate collaborative care discussions with patients with bipolar 1 disorder that include incorporating long-acting injectables as a potential management option. We are using a unique platform today that is designed to not only provide you with key strategies to facilitate the communication of long-acting injectables as an effective treatment option for bipolar 1 disorder, but also opportunities to reflect and dive deeper into those strategies. As you progress through the BriefCase, you will see key points of emphasis along with relevant resources and tools appearing at the bottom of the screen. You may choose to take your own notes by clicking the Add Note button at the bottom right and access those activities on the activity review page at the conclusion of the BriefCase. You can also access a robust resource library, including articles, guidelines, and practice tools by clicking on the book icon also at the bottom right. So let's begin with our patient Brenda, a 26-year-old single Black female who presents with a depressive episode. She's employed in the IT industry, but has been experiencing absenteeism and presenteeism due to depression. Her age of onset of depression is 16 years old. Her current comorbidities are generalized anxiety disorder, and she was diagnosed with ADHD as a child. She has no history of substance abuse or alcohol use disorder. She does smoke cannabis once weekly. Brenda has a family history of alcohol and drug abuse in the father, and depression in the sister, and suicide in the paternal uncle. In the past, she's also been prescribed antidepressants, but they were ineffective. In addition to a detailed clinical interview, you administered a diagnostic inventory and determined that her diagnosis is bipolar 1 disorder. You prescribed psychotherapy and an oral antipsychotic. She's returning today for her follow-up appointment. Hi, Brenda. It's good to see you again. How are you?
Hi, Dr. McIntyre. I'm okay, I guess.
That doesn't sound positive. What's going on?
I think I'm about to be fired. To show my commitment, I have taken on even more projects, triple what my coworkers are doing. And I just get no credit. I work 20 hours a day, and that does not bother me because I don't need much sleep. But my boss is saying that my work seems to be all over the place. And I rack my brain trying to figure out what I can do better. I could do A, I could do B, I can do C. I just realized I forgot to submit that last spreadsheet. I have so much work I have to do. I just feel like I have no balance.
Interesting. Brenda, how have you been doing with the psychotherapy and the medication that we discussed?
Well, with my schedule, did I mention that I work long hours? It's hard to get away for therapy every 2 weeks. As for the pills, let me be honest, I forget to take them 2 or 3 times a week. It is just one more thing I have to keep up with.
Yeah, I can understand that. With all that you've been going on here, and it can be very difficult remembering to take a pill every day.
Yes, Dr. McIntyre, it's not that I don't want to take any medicine. I want to be better, but it's just one more thing that I have to do.
When you did take the medication, did you feel really sleepy, restless, or develop any tremors?
No.
Okay, well, let's talk about more convenient ways to get your medication for you to consider. Since you did not have any adverse reactions from the pill version of the medication, we can try an injection version or long-acting formulation of that medication. You can still have the benefit of the medication, but you do not need to remember to take it daily, just once monthly. With a stable amount of medication in your system, you should see a reduction in your symptoms, which in turn can help you to achieve your life goals that we discussed.
Wait, There are medications that I can just take once a month that have the same benefit of medications that I have to take every day. That would be life changing. Wait, there has to be a catch.
No catch. But as we did with the first oral medication, let's not just talk about the advantages, but also some of the minor or rare disadvantages with the long-acting formulation. We will also need to discuss the treatment process overall.
That sounds fair. I am really interested, but I want a medication that is safe, that also fits into my lifestyle. So, what do I need to know in order to make a decision?
During the past 2 decades, the FDA has approved more treatments for bipolar than it has in the past 5 decades combined. And there's an expanding arsenal of treatments that clinicians have at their disposal. Interestingly enough, we've seen trends that are different in the pharmacology of bipolar. A recent publication indicated that second generation antipsychotics are the most frequently prescribed agents to bipolar disorder. And that's in keeping with some of the expanding indications for many of these treatments across various phases of bipolar disorder. It's a bit concerning that we're seeing a downturn in well-known mood stabilizers like lithium, as well as, in fact, a significant embrace of antidepressants. And that's something we're going to have to look at perhaps a bit more carefully. But I'm really, in fact, quite struck by the fact that second generation antipsychotics are the most frequently prescribed class of drugs for adults who have bipolar. The FDA, as you know, approves treatments across various phases of bipolar disorder for mania, for depression, and for maintenance. And it's important for us to be aware of the fact that treatments have different profiles of efficacy and safety and tolerability across these various phases. Remember, mania and mixed are usually included together. And what we can take away from the available indications is that most treatments for bipolar disorder are approved for acute mania and mixed. We have relatively few treatments that are approved for maintenance, and especially few treatments that are available for maintenance in the long-acting injectable formulation. And this is something I think we need to be aware of. And patients should be made aware of what the options are. I think our role, among others, is to serve as a source of up-to-date and accurate information, conveying that information to patients. What I've always been struck by is that despite the availability of some long-acting injectables for adults with bipolar disorder, as well as their FDA approval, at least for a couple of them, the percentage of people who are actually taking long-acting injectables who have bipolar is relatively small. In fact, it's a relatively small percentage. In fact, probably less than 5% in most clinics. And for me as a clinician, one of the observations I've made about myself is that I'm increasingly having this conversation, that is long-acting injectables for adults with bipolar disorder as a treatment option. And more specifically, I'm having that conversation more with so-called higher functioning patients, people who just simply prefer to be on long-acting injectables and not taking them only or exclusively because they're late stage or have tertiary illness or in fact have had difficulties being adherent. What we do know from the available literature is that long-acting injectable agents have benefits in bipolar. In fact, we have data now showing that they delay time to first hospitalization. There are, in fact, differences, though, between the agents. In fact, we're beginning to see that among the available, either FDA approved or available, that is, they may not be FDA approved in bipolar, that some of these agents are able to delay that time to hospitalization in people with bipolar 1 disorder. And we now have, in fact, data for not just all-cause hospitalizations, but psychiatric hospitalizations for example, the aripiprazole once-a-month long-acting injectable. And what's interesting is that when you really juxtapose, that is, when you put alongside each other the haloperidol long-acting injectable, the risperidone long-acting injectable, we are seeing some differences that favor the aripiprazole once monthly long-acting injectable with respect to all-cause psychiatric hospitalizations, or for that matter being the psychiatry hospitalizations particularly. So within the long-acting injectable category, there's differences between the agents with respect to their impact on overall hospitalizations as well as psychiatric hospitalizations. How do we get people engaged and thinking about LAIs, long-acting injectables, and bipolar? Well, it begins with having the discussion, moving people from pre-contemplation to contemplation. Let's think about it. And that's a collaborative process. We provide education, and more education to really inspire patients, but also to keep them up to date, to improve their so-called literacy on the diagnosis and the treatment. This is an evocative way to motivate people and giving people, in fact, the decision capacity. They make the decisions. This is patient-centric. And I have found patients to respond generally very positively to that approach. But I really think what they like is us to make options available to them, at least describe it to them. Now, with respect to other ways we can have these discussions, you've probably all heard of the GAIN model, the goal setting, action planning, initiate treatment, and nurturing change. We all have our ways that we work with patients. This I find to be a very useful framework. There's other ways of motivational interviewing, but it really begins with having the trust, having the empathic engagement with patients, providing information not just for them and maybe their family and friends, but also dealing with some of the myths, some of the distortions, some of the myths and disinformation that unfortunately is quite ubiquitous out there. And then working with patients on what are really, smart goals and goals that are achievable, that are specific, measurable, realistic, and can be achieved in a fairly short period of time. And really recognizing that this is a journey. This is an iterative process. It's a back and forth process. And that's really the way I like to think about all treatment journeys and all patient journeys that we do together. I've always been a fan of the SMART goals, very easy acronyms: specific, measurable, attainable, relevant, and timely. And I actually write that down on a progress note when I'm with my patient and just have that discussion. You will never achieve goals that you don't set. And it's a very superficial slogan or a statement, but it's so true. And so often patients will say, oh, that treatment didn't work and that treatment didn't work. And then I'll say, well, what were the objectives of the treatment? And they say, I don't know. So we need to, in fact, have these very specific objectives. And that process alone is therapeutic. And then we work with people and we select not just medication, but we also help them with lifestyle and maybe where appropriate psychotherapy to really guide them towards a successful achievement of these SMART goals. What we do know is that people who have bipolar disorder, like people in general, are non-adherent to some of the treatment recommendations. And by the way, that gap between what we really hope people will do and what's actually being done is often called the implementation gap. And non-adherence is a complex human behavior, and there's no single cause of non-adherence. One way to categorize causes is patient factors, clinical factors, and medication factors. And in terms of patient factors, they often bring certain biases, maybe, and misinformation about their illness and their treatment. Certainly for me, the clinical factors, there's many. Sometimes just the symptoms of bipolarity often take away from patients their insight, their ability to critically appraise the risks and the benefits of treatment. And that's something which we encounter not infrequently. And medication factors include aspects of efficacy and also aspects of tolerability and safety and accessibility. So there's many factors. And I think that an astute clinician recognizes that non-adherence is not a singular caused event. And we need to be cognizant and aware of these events. To the extent possible, try to anticipate these non-adherence factors and deal with them proactively. For example, what's the patient's understanding of their illness? What's the understanding of the treatment? And for too many patients, Dr. Google, which can be a very helpful source of information, often provides information that's misinterpreted by patients. So we need to deal with some of this information up front. One of the disconnects I've noticed is the perception of routes of administration and medication formulations that a patient has versus what a provider has, nurse or physician or what have you. And this is an interesting study because this really captures empirically that disconnect. Green is the patient's experience, and the pink, and I guess that's the yellowish color, is the pink is the doctor and nurse's concern, sorry, and the green is the patient's experience on a long-acting injectable, while the yellow is the patient's concern on a tablet. Let me just make it real simple. The green being on the low end is the patient's perception on a long-acting injectable, notice that it's almost always, with one exception, it's always at the bottom. What that means is that the patient's concern about that particular column is consistently less than the clinician's concern. And the patient's concerned about the LAI is often less than the oral. There's a notion out there that patients reject LAIs, that they don't like the needle, it's too frightening, it's punitive, it's looked at as a treatment of last resort, these types of things. But in reality, patients actually rate long-acting injectables in many cases ahead of orals, but also they rate them ahead of what their clinician or their nurse, their doctor might be rating them. So we need to explore these biases that people have and just try and reconcile that with the patients that we're seeing. There's always good and bad to many things in life. Let's talk about maybe the cons and the pros of long-acting injectables. And I think, when it comes to the cons of long-acting injectables, we have to deal with the stigma, for example. We're certainly having to deal with the administration, the anticipation or the reality of a painful injection. There's aspects of cost and access and insurance. And that's not an exhaustive list, but that's one set of factors. But that's also to be balanced against the pros. And one of the aspects I like about they reduce hospitalizations. You don't need to remember taking your medication every day because you take it, for example, once a month. And moreover, there's more flexibility in many cases for people. Other sort of cons to taking the agent is that, if you have a side effect on the long-acting injectable, you have to sort of maybe plan to maybe experience that in some cases more than the patient would like. And in some cases, I think that there could be some interference with the alliance with patients. You don't see them as frequently in many cases. And you can see on this slide a set of other liabilities. What I like about the long-acting injectables, they really deal with the issue of relapse control. They certainly deal with the issue of reducing hospitalizations. One of the questions we all ask ourselves is my patient having a relapse because they didn't take their medication or the medication didn't work? Well, if you're taking a long-acting injectable, you kind of got the answer. If you got a relapse, it's because it didn't work. So you're able to answer that question immediately. The other aspect is simply really patient preference. A lot of my patients say, I prefer to take one treatment a month than treatment 30 days a month. One of the theoretical issues in bipolar disorder, which I don't know the answer to, is whether long-acting injectables, by reducing relapses, can slow down the progression of the illness, which is well described. Progression meaning people are more prone to more chronic and episodes and more relapse-prone episodes. That's a theoretical issue, but certainly one I've often wondered about. With respect to the benefits of the pharmacologic treatments on the issue of rehospitalization, this is obviously not just a proxy of the severity. Obviously, if you go into hospital, you're severely ill, but it's also costly. It's costly to the patient, it's costly to the system. And there's been some really interesting data now showing that when you look at all of the treatments that we often think about within the pharmacopoeia of bipolar, so the treatments of bipolar disorder, what emerges is that when you look at really psychiatric hospitalizations, the drugs that reduce psychiatric hospitalizations in this very large analysis is lithium, which I still think is underutilized, and also long-acting injectables. And that's been seen not only in psychiatric hospitalizations, but also all cause. And I think these are treatments that, again, are not as frequently prescribed. Lithium and long-acting injectables stand out in this extremely large survey cross-national as the treatments that reduce hospitalizations in bipolar. That speaks to their ability to reduce the severity of illness and also to reduce the severity to the extent that they don't require hospitalizations. That obviously has very much of a cost advantage to the system and in some cases to the patient. So reducing psychiatric hospitalizations and all-cause hospitalizations is obviously a very significant benefit of lithium and long-acting injectables. Let's summarize with our SMART goals: specific, measurable, attainable, relevant, and timely goals. That is what I hope you will take from this CMEO briefcase to apply to your practice. Actively discuss long-acting formulations as treatment options for patients with bipolar I disorder. use evidence-based strategies to engage patients in treatment decisions, identify patients' symptom burden, life goals, and the role of long-acting injectables at improving patients' quality of life. Thank you for joining me today for Briefcase 4 of our 4-part CMEO Briefcase series on treatment hurdles in schizophrenia and bipolar disorder. To view additional briefcases on strategies to improve the detection of bipolar I disorder, as well as applying clinical updates on schizophrenia management and best practices for incorporating treatment planning for schizophrenia, please visit www.cmeoutfitters.com. Thank you again for participating, and thank you for providing the best of care for your patients.